Hey everyone, I hope you're all having a great start to your week. Happy Tuesday. I am hopping on Instagram Live to chat with a dear friend and colleague of mine, Dr. Matt Letterman. He is one of our REIs that work with us at RMA of New York in our Westchester offices. And he is a wealth of knowledge when it comes to many topics, including today's topic, which is basically all about GYN cancers, cancer awareness in general. We're really going to be focusing on what we call Previvors. So I'm going to add him into the chat and let him explain what a Previvor is. And to join. I hope everyone's having a great night. Here he is. Hi.
Hey, Lucky, good to see you.
Good to see you. I miss you. I feel like we don't get to see each other as much
I
as we used to when you
know,
were
I know.
in the
Always
Midtown
on
West office.
video.
I know,
Al-
exactly.
Always on video. Never. It's been a while in person.
It sounds like you've had, unfortunately, an eventful day.
Yeah, I was driving home. I was going to run an errand, and in my car, all of a sudden I hit the gas, and it wouldn't go.
Oh,
I was all right, and I'm driving. I just got on the highway, and then like an alert comes on. I'm like, oh great! And I was actually scheduled to take my car in on Thursday for an oil change and a tune-up anyway.
right.
So I called the dealership. They said, don't drive,
Oh,
get it towed.
no.
And so Stephanie came to the rescue and she helped out. I had to get back. I had a Zoom at 5 o'clock. So I was like rushing to get home for a patient
Oh,
Zoom.
my
So it was a little
God.
stressful, but all done now. All good now.
Well, thank you for still making the time to do this. I feel like so many people were excited to learn more about this. A lot of people feel very anxious about this topic. I'd love to just let people know a little bit more about you. I already told them that you are one of my fellow REI colleagues in the RMA of New York Westchester office, but I'd love to hear a little bit about your work when it comes to um, cancer predisposing mutations. You and I worked together on some research projects when I was your fellow, and now we're
Yeah. The good
colleagues.
old the
And
good old days.
exactly. No, but it's nice to be having this conversation. But I'd love for you to kind of explain what is a previvor and why are you so passionate about this topic?
First, the reason I'm so passionate about this is because my wife's a previvor. She's a BRCA2 carrier. And her story went shortly after we had my son, my mother-in-law, who had a family history of breast cancer, decided to get tested. She came back positive for BRCA2. She had prophylactic surgery.
Hmm.
And then my wife got tested. She turned out to be a carrier, had a prophylactic mastectomy, reconstruction. And then at the age of 40, when we said we're fine, we're done with our family, we had, two kids, we're a family of two, she had her tubes and ovaries taken out.
Hmm.
So my daughter's now a sophomore in college, and
Yep.
my son's a junior in high school, and both of them have a 50% chance of inheriting the gene and all the risks, the
Right.
fears, the stress that comes with it. And that's why this has been a topic that's very passionate to me in terms of how it affects reproduction and what options, patients have, whether that they've had cancer, whether they're previvor.
Hmm.
And, what is a previvor? A previvor is someone who's at risk for having cancer, who has a genetic mutation, such as a BRCA mutation, a Lynch mutation, as well as numerous other cancer predisposition mutations, who have a risk, and therefore, you know, you know, have the option of some preventive measures, some
Hmm.
screening that go along with it. So
Yeah.
a previvor is someone who has a cancer mutation that's at risk but doesn't have cancer.
Can you talk a little bit more about the BRCA gene? Because we have a lot of patients that are known carriers of the BRCA1 or BRCA2 mutation. I would say it's one of the more common ones that we see. And obviously, there are so many other types of cancer predisposing mutations that are now coming to light. But I'd love for you to, since you have a personal connection to this, and because we see it so much, can you talk a little bit about what BRCA is?
So, there's both a BRCA1 and BRCA mutation, and that's the number one cancer predisposing mutations.
Hmm.
And what it means is, it affects more women than men, but men often get neglected. But it's women with a BRCA mutation are at risk of early onset breast and ovarian cancer.
Hmm.
They're also, those are the big ones. That could be in the 20s, in the 30s. BRCA1 is more risk for ovarian cancer than BRCA2, but still, a risk.
Hmm.
Other risks include, skin cancer, uh, pancreatic cancer, which is not a great screening test for, you know,
Right, right,
metastatic prostate
right,
cancer.
right.
Um,
Another
and,
another big one is Lynch syndrome too,
yeah,
right? When you
yeah.
think about colon cancer. I guess, this makes people feel anxious, and I feel like people have learned a little bit more about this with the advent of tests like 23andMe. But, not everyone who carries these mutations is aware of it. And so, how do people gain this awareness about their health history if they don't have, the knowledge of their family history? They have a really small family. Like, how do people pick this up? And do you feel like the screening is done in a universal way, or it really depends on who your doctor is? Are there guidelines that you recommend people follow when it comes to who should have these conversations and get these tests done?
A lot of it, depends on, family history is the big one when it
Hmm.
comes to, these cancer genes. That's like, the big one. And, a lot of it depends on the kind of questions that your doctor asks. So whenever I
Right.
see a new patient, I'm not just talking about fertility related questions. I'm also asking about, family history of cancer.
Hmm.
And if someone has a significant history of cancer, then we talk about options about having, a genetic evaluation with a cancer geneticist to determine if they should be screened. So,
Right.
red flags are someone, with, multiple family members, with certain, with cancer or certain types of cancer or early
Hmm.
onset cancer of some of the common cancers of breast, endometrial,
Hmm.
colon. And when you think of colon, you think of, Lynch syndrome, which you mentioned before,
Yes.
or, or someone with multiple cancers in a family,
Right.
or rare cancers such as like pancreatic cancer,
Yeah.
ovarian cancer, male breast cancer, metastatic prostate cancer, pancreatic cancer,
Right.
or someone who has or in the family, there's a history of a BRCA mutation
Right.
or a Lynch mutation. So some of those are the red flags. And women, or and even men of the Ashkenazi Jewish population, there's a higher prevalence within that population. About 140 Ashkenazi Jews are carriers for the
That's
mutation.
a
That's
really
pretty,
high percent.
that's
Yeah.
really high when you think about
Yeah.
it. Much higher than, some other things that, we're screening for these days.
Right. Right. And it can be sometimes hard, especially in certain cultures. Like, I know for myself and a lot of my Indian patients, East Indian patients, they're like, my parents have had a cancer and I don't know what it is because they don't really want to disclose it to me, or my grandparents don't really talk about their health history. So that can be tough as well. But
Yeah.
I think something that often can be misleading to patients. First off, they definitely look at me like I have two heads when I'm like, tell me about your family history. And they're like, well, my mom had me at 43, and they're focused really on fertility. And I say, no, I want to know about any and all cancers. And a lot of times they're not connecting the dots because there's this assumption that it has to be everyone on this side of the family has the same cancer. But exactly what you said, like the BRCA gene mutation, yes, there are more common cancers that it can be associated with, but there are so many other types. So if you have colon, if you have stomach, if you have prostate, if you have ovarian or uterine, all of those things could be related to the same underlying gene mutation. And that's really important for people to have an awareness of.
Yeah, no, I completely agree. And men, when it comes to BRCA, you don't even think of men with BRCA.
Yeah,
They're at much less risk, but 50% of their
right.
daughters will inherit it and the risks that come with it.
Yes,
And when
exactly.
and I've seen a lot of patients who've done IVF to screen it out, which I'm sure we'll get to, talking about, but they've done it for, from the male. It's not
Yeah,
just the women who could pass
yes,
on it, it's also the males and their daughters that,
yeah,
can inherit it, and the risks and the fears that come along with that.
yes. Pretty much any gene mutation that runs in your family, if you haven't been tested, this is something that you should talk about with your fertility doctor. Not only is it important to know about your own health, but there are things we're going to talk about in terms of an opportunity or chance to avoid propagating it to future generations, which is a really amazing opportunity thanks to technology that we have available today. Um, all right, so I want to talk about a little bit more about that. Let's say hypothetically a patient finds out that someone finds out I carry X mutation. This is something that someone in my family was aware of. So then I got tested. Now I know I have it. Um, let's use BRCA as an example. What would you, I mean, it's overwhelming. What should someone's first step be, in your opinion, having the experience and expertise that you have?
Well, I think the first thing is go talk to someone who
Hmm.
knows what the options are. Like, key is power knowledge, like empower yourself to know what the options are. And so, for example, what I've been trying to advocate for when someone say gets diagnosed with BRCA, they often go to a cancer geneticist. They get diagnosed with BRCA, and oftentimes they're referred to a GYN oncologist, a breast surgeon, but they also should be referred to a fertility specialist to talk about how that affects building and planning a family, whether they're in their 20s or
Yeah.
30s, just even though they may not be thinking about a family now because they're, say, 25, you at least could empower yourself with the knowledge of what that means in the future.
Yeah.
There are things we could do to maximize chances of having a successful family, such as we could do things by freezing eggs,
Yeah.
freezing embryos,
Yeah.
screening that mutation out from the offspring. So there's preventive measures that we could do,
Yeah.
and at least one could learn about those options, even though they may not think about doing one of those options in the near future,
Hmm.
but they could therefore plan because they have the knowledge.
Yes. Well, I think a lot of people at face value maybe don't understand why egg freezing could be really beneficial if you carry, let's say, the BRCA mutation. And I always go through, there's multiple reasons. I feel like we should go through those. Obviously, you mentioned the first thing, which was if you decide now, you don't have to decide now, but later down the line, even that you do when you're ready to have children, maybe you want to skip straight to IVF because you want to make use of the ability to create embryos and then test them for the BRCA mutation, BRCA1 or 2, and then avoid passing it on to future generations. That's a luxury. That's a great thing that you can do, right? But beyond that, there are real medical reasons why it can be very smart and strategic to freeze eggs. Can we talk about some of those?
Yeah. Well, you hit the big one is like if you know you want to screen out the BRCA mutation, you might as well freeze your eggs at an earlier age. So
Yes.
you can get more eggs, better quality eggs that result in a chromosomally normal embryo
Yeah.
because you lose 50% of those embryos to the mutation. So you're going to do much better and set yourself up for success
Hmm.
if you know you want to screen it out.
Right.
But even in women who are not necessarily sure they want to screen out or not interested, there's still some beneficial reasons why to, say, freeze eggs. Number one, God forbid they got diagnosed with cancer. Chemotherapy
Especially
is very,
especially ovarian
yeah, especially
cancer.
ovarian, which it's harder to freeze eggs in that situation.
Right.
It's kind of most of the time you can't. But if you got diagnosed with breast cancer, obviously chemotherapy is harmful to the ovaries.
Hmm.
And yes, you could freeze it right before then, but you're freezing now before that, so it takes some of that stress out in that situation. Still,
Yes.
obviously, a hard thing to go through.
Yes.
So if you happen to be diagnosed with cancer,
Yeah.
there are also some studies that show that BRCA mutation carriers have lower ovarian reserve, what we call diminished ovarian reserve.
Yeah.
And it's not all patients, but
Yes.
I definitely see a subset.
Yeah.
There's 100% like a subset out there. We don't know why.
Yeah.
And these are young women who late 20s, early 30s who come to us. We look at the ovaries, they have lower follicle counts, they have lower
Hmm.
AMH levels, which is a blood test, a marker of one's ovarian reserve.
Yeah.
And we clearly see that. I had a patient about a year ago who came, with that situation,
Hmm.
like really low AMH, not much in the ovaries. We only got a few eggs,
Yeah.
still got it took a few
Yeah.
cycles, but we still got an embryo that was
Hmm.
chromosomally normal and BRCA negative. She's pregnant
Amazing.
and delivered. So
Yay.
even in those cases, when low markers are reserved, one could still be successful.
Yes.
So
And even
that's
if you have normal reserve, but you know you're a carrier, now I always kind of have that in the back of my head, and I tell patients about that. Listen, this might predispose you to going through rapid loss of your follicles at an earlier age than what we would typically expect or see. And so if you think there's a chance that you're going to want to freeze your eggs, it's better to do it sooner rather than later.
and when you
Use
do
the
it at your
eggs that you
peak
have.
versus when it's going
Right.
down, we can't predict that.
A lot of
So
people don't know that
yeah,
fact. It's not publicized nearly enough.
yeah. I mean, we wish we could predict it, but
Yeah.
until we figure out how to get that crystal ball going,
Yeah.
it's one of the things that we don't know.
What about
Another,
risk reducing
well,
surgery?
that's what I was going to go. So, because BRCA carries a risk of, ovarian
Yeah.
cancer, studies, there's a recommendation for them to undergo risk reducing surgery remove the fallopian tubes and ovaries between the ages of 35 to 40, or individualized based on age of onset of ovarian cancer in another family member, or once childbearing is complete. So obviously, that plays a role in fertility.
Right.
So for women who are, whether single, married, who are not done having a family or have not started a family, they could freeze eggs or embryos before undergoing the risk-reducing surgery, take out the fallopian tubes and ovaries, and have frozen eggs or embryos.
Right.
And also, interestingly, a lot of women don't know, and men don't know, that you don't need ovaries to get pregnant.
Yes.
We could give back hormones to help support the uterus, the early pregnancy, until pregnancy takes over, without having ovaries. And if we have eggs or embryos, that gives them a chance.
Yes.
So for women who haven't started a family, who want to take out their ovaries to reduce the risk, we could freeze eggs.
Right.
If they have a partner, we could take freeze embryos and give them the option to start the family when they want and when they're ready.
I think that that's one of the most mind-blowing facts that I love to share with patients, is that once you have frozen eggs or embryos and they have reproductive potential, it doesn't matter if your ovaries are there or not. We don't really need them anymore. Obviously, they play a role, in producing estrogen and protecting your bone and your heart health. So that brings me to a question that came up when I was gathering questions for today's discussion. And it's nuanced, obviously, and a complicated, not a yes or no, black and white answer. But for people that have taken their ovaries out as part of a risk reduction strategy, are you aware of people using hormone replacement therapy, especially if they're doing this early in their late 30s?
Yeah, and I could share my wife's example. She had her ovaries taken out at 40, her tubes and ovaries, and she's on hormone replacement therapy. She's she uses a marine IUD, so it's local progesterone and an estrogen patch. And nowadays we're learning more about menopause and menopausal transition, and the fear used to be stopping hormonal therapy earlier. Now it's more and more studies come out that you could even go longer with that. So she's on an estrogen patch to help with bone, because it's very important. You take out the ovaries. Ovaries are important to make estrogen, which is very important for bone health.
Yeah, I think it's incredible though, because a lot of patients worry when they have these types of mutations about being pregnant for 9 months and what the hormones from the pregnancy might do. And I think someone who goes the route of trying to reduce as much risk as possible, has something frozen, maybe they had a preventative mastectomy, maybe they've had their ovaries removed, they can probably breathe a little easier knowing that, and then go through a pregnancy that way. And we've had lots of patients with that type of scenario, and it's pretty incredible.
One thing I've learned from my patients, and I've seen a lot of patients who are previvors or who had cancer, is listening to the stories and their journeys. I find every journey so interesting, so different, and it always teaches me everything. I learned a lot from my wife and my personal situation.
Right.
One story that I like to tell about a patient of mine who did IVF to screen it out. And her story went, she inherited from her dad, and she got tested in the mid-20s because of her dad being positive. She was positive, went every 6 months for breast imaging, and her plan was, I'm going to get an MRI. After the MRI, I'm going to start my family with my partner. MRI was not clean, very early breast cancer. All she needed was certain mastectomy, no chemotherapy, and said, I did everything that I could possibly do to try and prevent this, and I still got it. And she decided, well, what I went through was so unimaginable, just the stress. I don't want my child to have to go through it, so I want to screen it out.
Right.
And she was unlucky in that she had a low AMH, a low reserve, took a few cycles, but now she has 2 beautiful kids, 1 boy, 1 girl, both free from the BRCA mutation, end of the cycle. And her kids, because what she wanted to do, and one said this is not for everyone. Everyone has may choose different paths, but she was able to end the cycle in the family. So what she taught me was just the stress of going to the imaging procedures. Am I going to be clean?
Right.
Great, I'm clean this month. 6 months later, you can't imagine that stress of, going through that. It's so hard to put yourself in that position. So it's one of those
Yeah.
things that I always learn from my patients.
Yes.
And it's one of the things you just can't, it's really hard to put yourself in that situation.
Yeah. Yeah, definitely. I have so much respect for patients that are in this situation because it requires a lot of forward thinking, being strategic, and it's not always easy to confront scary topics like
Yeah.
this and think about the potential risks and to think
Yeah.
10 steps ahead. And
Yeah.
I think what you said is completely correct, that the first step is really having a conversation. I think it's important for people to realize that coming in to have a conversation about this doesn't mean you're committing to anything. And
Yeah.
some patients will meet with our genetic counselors, they'll meet with us, and they'll still say, you know what? I've decided to not move forward with creating embryos and testing. It's not something that you have to do, but it's important for everyone to be able to make an informed decision and understand what their options are.
Yeah. I couldn't agree more. The key is just knowledge and
Yeah.
power.
Yeah.
Know what the options are, know how it affects you, and then decide.
Right.
You know, some will do IVF to screen out. Some will, do IVF just to create embryos because they may be taking out the tubes and ovaries. Some may
Right.
freeze eggs. Some may choose to do absolutely nothing and say, you know what, I am fine with trying on my own or whatever, whatever is my path is.
Hmm.
But the key is having the knowledge to make informed decisions. And that's why, coming to speak with someone who is familiar with, fertility, how a mutation like this impacts that and
Hmm.
how it affects building a family, you know, I think is important. And one of the things I've been trying to get out there is that, you know, someone in that situation who is a previvor, talk to a fertility specialist to learn what options you have and to gain the knowledge so you can make informed decisions.
I think one big barrier, and I don't know if you'll agree in terms of your experience with patients, tends to be fear. Like a lot of patients, especially with the BRCA mutation, and they're worried about having estrogen sensitive tumors in their breast. They are afraid of going through the stimulation process required, right? The 8 to 10 days of shots. It's overall like a 2 week process, and yes, your estrogen levels can get higher. We do this for patients with active breast cancer. If they need to do chemotherapy, especially, we'll make the time and take the 2 weeks to do this. And their oncologists will encourage them to do it. Often in those scenarios, we're going to use a medication called letrozole to try to keep the estrogen levels at bay. And, we just want to try to minimize risks wherever possible. In reality, it's such a transient rise in your estrogen, it's probably not going to move the needle at all. But how do you address these fears in patients who don't have an active cancer diagnosis? Do you use letrozole in patients who are BRCA carriers? Should they be concerned? How do you counsel patients about that?
Whenever I see, a patient who is, a previvor, if they have breasts, I will use letrozole.
Hmm.
Once again, letrozole is a medication we use, for a breast cancer patient, who's going to get, who we're going to
Hmm.
stimulate before before they undergo chemotherapy. We'll use letrozole in their stimulation cycles. I'll use them for, BRCA patients who still have breasts. If they've had a mastectomy, oftentimes, I won't use letrozole because they have no, breast tissue.
Right.
Um, or unless there's certain concerns, we could still use letrozole.
Okay.
And they still do as well. The one thing letrozole does is, you lose estrogen as a marker for those cycles, but oftentimes you don't necessarily need it. You follow the trend of not the absolute numbers, but the trend
Yeah.
and, how the cycle, is progressing.
Yeah. Okay. That's very helpful. But you would say there really isn't data or any reason that we're worried about predisposing someone even further to developing an estrogen sensitive tumor because of this short window
Yeah.
of time
It's
that
a
they're
very
getting
short
stimulated.
window, where the hormones get out of your system
Yeah.
really quickly,
Yes.
with the type of trigger shots that patients take. Within a week, they're getting a period, they're back to baseline. And remember, in women who are pregnant,
Hmm.
their hormones elevated, for a lot longer,
Yep.
you know.
Yep.
And the studies that, even though they're not the biggest studies, the best of studies, the studies that looked at BRCA carriers who've undergone fertility treatment have shown that there's no increased risk of breast or ovarian cancer,
Yep.
that it's, safe to do. And a lot of the patients will use the medication letrozole,
Hmm.
when, women still have breasts,
Right. Right. Okay, this was super helpful. We addressed most of the questions people sent in to me. I want to give a shout out to Allie, who is in the comments. She is a major advocate in this area. She's someone who has a public account, froze eggs with RMA of New York, and talks about it a lot online, very openly about being a BRCA 1 and 2 carrier. So it's kind of a unique situation. And she actually does this really cool art where it looks like breasts, also looks like eggs, depending on who you ask. But I have it on the back wall of my office. But it's a very sentimental gift because I think everything she's doing is so fantastic in terms of spreading awareness and education. So thank you for tuning in, Allie. I definitely think that this is such an important issue. A lot of people just don't know about it. It's not necessarily intuitive, but it's so important, as Dr. Letterman described, to really pay attention to your family history. When we ask you about family history, we're not just focusing on fertility. We're asking because we really want to understand what the reproductive risk is, and it's important for your own general health as well. So I guess in closing, I would love for you to share, since you're so passionate about this and you've been involved in advocacy in this area for so long, what are some top key references or resources that you refer patients to? I think sometimes this can feel like a very isolating thing for someone to be navigating, especially if they're, this is like a really can be very heavy for certain patients, especially in their 20s as they're trying to make all these really important decisions. It's important, I think, to have community and resources. So do you have any recommendations?
Well, there's a lot of online resources and organizations out there that are advocating for, for previvors and breast cancer survivors. There's TEAL, which stands for Tell Every Amazing Lady About Ovarian Cancer. There's FORCE, which is Face and Risk of, of her, cancer. There's Sharsheret. There's a lot of different organizations out there that are nice online resources. And there's lots, support, there's information. But when Lucky was a fellow, we put together a manuscript, for, kind of what we spoke about today, just, what does BRCA mean for fertility?
Yeah.
And that could, be found online.
Yes.
And covered a lot of what we spoke about.
We did a questionnaire study, remember?
Yeah, we did that. We did the questionnaire, too. Yeah.
Yeah. No, because it's so important. And as you said, no two patients, no two previvors are in the exact same situation. And everyone's path can look really unique and individualized. So really important to talk to experts like yourself. Where can people find you if they want to be your patient?
So, I'm in our, Westchester, part of the Westchester team up in, we have an office in White Plains, Mount Kisco. I spend more time in Mount Kisco. But the beauty is a lot of our appointments are virtual.
Yeah.
We do a lot of Zoom appointments. So I'm always happy to chat with anyone about this topic. I've treated patients in different states, when it comes to this topic. And that's the nice thing of telemedicine. You don't have to be next door.
Yeah.
But this is a topic that's near and dear to my heart because of my family connection. And, lucky if I've, been, talking about this topic for, quite some time.
Yeah.
And, it's getting more and more, not a lot of people out there are aware when you think, of this topic. You'd be surprised how many when I do a cancer history and I find out there's a bunch of cancer in the family and I, mentioned the BRCA, you'd be surprised how many never heard of it,
No, I know. It's shocking to me that in 2024, this isn't being talked about enough. So I'm really grateful that you took time out of your Tuesday night to share your wealth of knowledge. And obviously, this will be probably the first of many conversations because we do need to keep spreading awareness. But it was so nice to catch up with you. Thank you so much.
It was great to catch up. Thank you for having me on my first Instagram Live.
Oh my God.
Hopefully not the last, but definitely my first Instagram Live.
Very professional and totally at ease. So I had no idea this was your first one.
Oh, yes. First and hopefully not the last.
Definitely not the last. Have a great night. Hopefully I'll see you soon in person.
Yes. And be well and all hello to the family.
All right. You too. Bye.